Good afternoon, everyone. I'm Akansha. I'm one of the Advanced Imaging Fellows from Sydney Children's Hospital. Today, I'll be talking about the usefulness of MRI in diagnosis of pediatric cardiac tumors. Now, we know they are very rare, but occasionally when we do come across with a patient who has a cardiac tumor, it's important to know what is the most probable diagnosis, what would be the prognosis, and whether this kind of tumor is amenable to surgical intervention or not. This particular article published by Zon in 2007 gives us very good idea about the incidence and the frequency distribution of various tumors in the pediatric age group. Now, we know that most of the tumors are benign, but we do come across malignancy once in a while. Actually, we've had 2 malignant tumors just this year, which I'll talk about. Now, people who are interested in MRIs would like to know the kind of imaging protocols we used. For that, this article by Motwani et al. Is very useful, which will tell us mostly what we do is first do axial stack to find the location of the tumor, and then do T1 weighted, T2 weighted imaging, then give gadolinium contrast, do the first pass perfusion, and thereafter lead gadolinium enhancement. Obviously, the protocol is changed depending on the findings we have on the table. Now, this diagram tells us the most common location of various tumors, but this is just a suggestion of what the tumor could be, not diagnostic. This particular table given by Burkham et al. In the article Magnetic Resonance Imaging for the Evaluation of Cardiac Tumors is one of the most important tumors that I personally go back to every time we scan a tumor kit, because this just gives us a summary of what would be the most probable diagnosis in a child who has the kind of data that you've collected. We'll come back to this table every time we talk about a tumor. So let's go and talk about tumors. Benign tumors, rhabdomyomas, we know they are the most commonly associated with tuberous sclerosis, can occasionally present as SVT in infancy because if they are present around the AV junction, can act as an accessory pathway. And some of the people actually think they are not tumors, but they are hematomas of the muscles. So yeah, we'll leave that up to discretion. I'll just show some of the examples of the tumors here. This is one of the antenatal diagnosis where a mass was found in the RV cavity. In the post-natal MRI, we can see a tumor attached to the RV free wall, separate from the papillary muscles, which is iso-intense on T1 and hyper-intense on T2. When I say iso-intense or hyper-intense, it is basically comparing the signal intensity of the tumor as compared to the normal myocardium. So this is hyper-intense as compared to the normal myocardium. It does not take up gadolinium in the first pass perfusion, which basically means that the tumor is not a hugely vascular tumor. I'm not trying to confer that the tumor is avascular. What I'm trying to say is that here, the dynamic perfusion suggests that if the tumor doesn't have the same signal intensity or high signal intensity in first pass perfusion, it is not a highly vascular structure. Now, in a rhabdomyoma, it also does not take up gadolinium in the delayed gadolinium enhancement. Now, the tumors that actually take up in the delayed gadolinium enhancement are the tumors which have fibrous structures or have huge vascularity, which take up gadolinium, and it takes a little while for them to wash out compared to the normal myocardium. Now, here we have an example of an LB rhabdomyoma, which was an incidental diagnosis in a child, a small tumor that can be seen attached to the interventricular septum, iso-intense on T1, hyper-intense on T2, does not take up gadolinium in first pass perfusion, as well as in delayed gadolinium enhancement. We can have rhabdomyomas in the atrium as well, more commonly found in ventricles, but can be found in atrium as well. Here is an example of a rhabdomyoma attached to the RA roof. Iso-intense again in T1, but hyper-intense in T2. Now, this coming back to the table, now this is the data that we have collected. Now, when we go through the table of the differential diagnoses that are present for us, here we can see that it can be iso or hyperintense in T1. It is usually hyperintense on T2. It doesn't have first pass perfusion nor delayed gadolinium enhancement. And given the location, it is more likely a rhabdomyoma. For the atrial rhabdomyoma, you can have a differential diagnosis of lipoma, but then it did not have high signal on T1, which is seen in lipoma. Whether it could be an atrial hemangioma, doesn't look like because it was not that vascular, did not have perfusion, high signal intensity on first pass perfusion. Could it be a myxoma? But again, unlikely because it did not have any uptake in the delayed gadolinium enhancement. So this is how, when we collect the data, we go about thinking what it could be, and we come to the diagnosis of the most probable diagnosis this tumor would have. Now, for a fibroma, we know that it can invade the ventricular muscles by the interdigitations it have, can cause systolic dysfunction or ventricular fibrillation. Either of them can cause congestive cardiac failure. Mostly surgical resection is recommended, but it is possible that the surgeon might not be able to take the whole of it because of the interdigitations in the ventricular septum. But again, for that planning, it is important to know the extent of the tumor. So again, cine images of an 11-month-old kid referred for murmur and feeding difficulties on the echocardiogram was found to have a tumor. Hard to know what kind of tumor it is just by these images, whether it's a rhabdomyoma, fibroma, sarcoma, hemangioma, hard to know. So let's go about thinking about it. So on T1 weighted imaging, it is hyperintense. On T2, it is hyperintense. Dynamic perfusion, it doesn't take up GAD. But the clinching diagnosis here is the delayed gadolinium enhancement. Now, a fibroma on delayed gadolinium enhancement will have a well-defined core of signal intensity, which is taken up by the fibrous tissue. And in the middle, the core will have decreased signal intensity, mainly because of the calcium. The core of a fibroma is usually calcified tissue, and therefore you will have this typical appearance in a fibroma. Well-defined border with a dark core. Teratoma, second most common tumor in fetus and newborn after rhabdomyoma, most common in the pericardial cavities, usually are amenable to surgical resection. If they are huge, can sometimes compress the SVC and RA. Usually they are this cystic, multiloculated, they have cysts, they have solid structures, multiloculated structures, mostly in the pericardial space, sometimes can compress the SVC as well as the right atrium. Now here in T2 weighted imaging, it will be hyperintense given there's a lot of fluid out there. The Dixon is a protocol that is used for defining borders variables. We can define the borders of the tumor with the heart and make sure that there is no overlap. And in delayed gadolinium enhancement, there will be heterogeneous uptake. So we can go back to it and we come back to the diagnosis. Myxoma, very common tumor in adults, like the most common primary tumor in adults. Less so in pediatrics, but we do see that in second decade of life. It can be associated with Carney complex, which is a familial complex, and in those cases, you can have multiple myxomas. It can also be associated with other multiple endocrine disorders. Now, we all know the appearance of something of a tumor which is large but has a pediculated stalk up connected to the atrial septum. The cine images of the same. Then on T1 weighted, it will be isointense. On T2, it will be hyperintense. Not perfused in the dynamic perfusion or the first pass perfusion, and will have heterogeneous uptake in the delayed gadolinium enhancement. Then you've got hemangiomas. Hemangiomas are very rare in kids, but should be suspected if you find multiple hemangiomas on the skin. They can present with ventricular tachycardias. They can also present with pericardial effusion if it ruptures or if it leaks in the pericardial space. Now again, a cine image of a 6-month-old child who's got a tumor. Difficult to know, rhabdomyoma, fibroma, hemangioma, sarcoma, hard to know just with the cine image. T1 weighted image, isointense. T2 will be hyperintense, and the clinching diagnosis here is the first pass perfusion. We've seen first pass perfusion of the other benign tumors. None of them gave us the signal intensity as a hemangioma does. As soon as the gadolinium enters the heart, the whole tumor lights up. Lights up is a layman word, but gives you the signal intensity required. It will also have heterogeneous delayed gadolinium enhancement. So given, again, going back to the vascular tumors, the hemangioma, it gives you the first pass perfusion. Now, fibroelastomas are again very rare tumors, again more common in adults. They are very small pedunculated tumors, avascular tumors, which are associated with the valves. They can cause dysfunction of the valves and lead to important regurgitations. Now, here is a very small structure attached to the septal leaflet of the tricuspid valve. In the short axis cut, we can see its attachment to the septal leaflet. Now, This on dynamic perfusion, it will not take up gadolinium because it is an avascular structure. And similarly, in delayed gadolinium enhancement, it will not show any delayed gadolinium enhancement. This was just an interesting picture of the aortic and pulmonary valve, both having fibroelastoma. I've just included here for completeness sake. Now, pericardial cyst is actually not a tumor. It can be said as a pseudotumor, but it's important to differentiate it. Because you will find kids who have been referred with a tumor in the pericardial space, and it's hard to know whether it could be a teratoma or a pericardial cyst, similar to this kid. But the MRI characteristics are very good in differentiating either of them. It will have high signal intensity in T1 as well as in T2 weighted imaging. It will not take up any gadolinium because, again, it is an avascular cyst that is enclosed in the pericardium. And it will also not take up any gadolinium enhancement on the delayed GAD. So it's one of the pseudotumors that we say, but it's important to diagnose that. Lipoma, again, more common in adults, less so in children, but it will be mostly a subepicardial structure, very well encapsulated and very high signal intensity on T1 and T2 weighted images, will not take up any gadolinium. Now, malignant tumors, rare in children, but important to note when it's a large tumor with ill-defined borders, it has more than one chamber involvement, it has heterogeneous enhancement on T1, T2, as well as the gadolinium. We've unfortunately had 2 kids this year with malignant tumors, and I'll show you the images. This characteristic mostly has been taken from the adult world. Now, this was an 18-month-old referred for cardiomegaly on chest X-ray. On echocardium was found to have a tumor in the interventricular septum, but there was no effusion, and the echocardiogram was done 2 weeks before this MRI. So within 2 weeks, the kid developed such significant amount of pericardial effusion is again concerning for malignant tumor. It was iso-intense on T1 weighted imaging, but hyper-intense on T2 weighted imaging. The dynamic first pass perfusion did not have very high signal, but it did have heterogeneous signal. If you note here, there was some heterogeneity in the first pass perfusion, which was a clue. And again, the delayed GAD was very heterogeneous. You've got the normal myocardium here. It did not have any pattern specific to any benign tumor. It was very heterogeneous. In this kid, we basically did an RV endomyocardial biopsy by catheterization and found it to be rhabdoid tumor. The kid is under chemotherapy at present. This kid, it was an 8-month-old kid presented with COVID positive. X-ray showed cardiomegaly, large pericardial effusion that was drained, but also showed this tumor which extended all the way up till between the SVC and aorta. And all the adult cardiologists will tell you that any tumor that extends between SVC and aorta should be highly suspicious for a malignant tumor. It was hyper-intense on T2 as well as T2 weighted imaging. Did not really have high signal on dynamic perfusion, which was something that made us think whether it could be a teratoma, and had a very heterogeneous late gadolinium enhancement. This kid had an excisional biopsy and was found to have synovial sarcoma, very rare. Only 17 cases in the world have been identified. This kid is also on chemotherapy. Secondary malignancy, very rare in pediatrics. This is the case of a metastatic medulloblastoma, which is basically involving the whole crux of the heart. Pseudotumors, just to know of, it is important to differentiate thrombus, cysts, and normal structures, basically comedon ridge near the left upper pulmonary vein and the left atrial appendage sometimes can be called a tumor. It is important to note that. And this is just the thrombus, which is more commonly seen in adults post myocardial infarction and severe systolic dysfunction, which is the case here. But it's important to note that it is a pseudotumor, a thrombus, and not really a tumor. So the conclusions, MRI is not only important in the diagnosis, but the main word here is tissue characterization. The tissue characterization that MRI gives, no other non-invasive imaging modality or invasive imaging modality can give. It also provides input in surgical planning and post-operative surveillance of kids with tumor. Thank you so much.